Good morning, and if you're on the East Coast, happy early after lunch. Hope you're having a great day. Very excited to be live with you today and go through all of your questions. We're going to start out with the questions that have been submitted through YouTube and Facebook and all of our social channels, including LinkedIn. So keep them coming, by the way. Thanks very much for the questions you've given us, and we're very excited to get more of them. I have to say, I'm super impressed with the questions. They're very interesting, very detailed, and very informed. We're going to go over all of them today, get you the answers that you need and deserve to make sure you get the right care and care that is always the very best practice. Welcome back. I'm very excited again to go over these questions with you. Let's go to the screen and take a look at what came in over this last week. First, I had this is from Ashwani Yadav and came in just 6 hours ago. I had a partial ACL tear and a grade 2 meniscus tear. Is surgery required? Well, that's a great question. And obviously you've had an MRI because the grade 2 ACL tear is only something that could be diagnosed, and frankly, the meniscus tear as well, and confirmed by magnetic resonance imaging. So now the question comes, should I have surgery? And the answers I'm going to give you are the general answers. There may be a little more specific based on your particular case, but starting out with the ACL tear. Partial ACL tears, when the knee is still stable, generally most orthopedic sports medicine specialist surgeons will give them a chance to heal on their own. If your knee is not functional despite a good attempt at 6 to 12 weeks of self-healing, then they do look toward surgery. But most of the time they're going to try to heal it on your own. This is an example of an ACL tear in our picture here. And you can see this is the knee, and here's the anterior cruciate ligament, and here's a tear that's part of the way right through it. Probably very similar to what Ashwani is dealing with. The second question is about the meniscus, and there's two ACL tears are reconstructed. Meniscus tears are either debrided, which is called meniscectomy, or repaired, which is a more involved operation where the surgeon stitches up or tacks down the broken or torn ACL. Most surgeons recommend repair of tears if you are under 50, sometimes if you're under 60, but certainly the older you get, the less likely you are to benefit from a meniscus repair. The need for a meniscus repair depends a lot on the type of tear that you have. A bucket handle tear, for example, where the tear is around the outside and it bucket handles up like a paint can. A bucket handle tear in a young person is a good one to repair. But most people who have meniscus injuries end up having surgery because their knee is locked and they just can't move it. It's so painful that it's locked in one position. And for those people, meniscectomy is more the treatment of choice. All right, these are such good questions. Let's go to the second one. This is from K-Cool and came in an hour ago. Hi, Doc. Hey, K-Cool, how are you? Nice to talk to you. Question, if inflammation process is helping to eat away the disc, would not anti-inflammatories delay healing or eat up process? I love this question because it shows me a person who's very smart and is really thoughtful. So inflammation and healing are the same thing, but we call them by different names. We call it healing when we like it, and we call it inflammation when we don't like it. So we go on anti-inflammatory diets. We don't go on anti-healing diet, right? Even though on a cellular level, on a mechanistic level, they're the same thing. So yeah, in theory, if we took an anti-inflammatory, we would slow down healing. The most common anti-inflammatories are Aleve, which is a non-steroidal anti-inflammatory. Tylenol, which is anti-inflammatory but not an NSAID, and aspirin, which is also anti-inflammatory in a different category but not an NSAID. All three of these, in theory, could slow down healing, but in practice, it's inflammation when it's more than healing. It's gotten to the point where the healing process is out of control, and we need to turn down the volume a little bit in order to make it less painful. Could it theoretically slow it down? Yeah, it could. That's the price you pay for that improved performance. All right, next question. Can you address the cost? This is from Noreen O'Donovan. And Noreen is commenting on this Phoenix Spine and Joint. What is the DVR procedure? Yes, Noreen, I will address the cost of DVR. First of all, DVR, direct visualized rhizotomy, is a procedure done through an endoscope for people who have benefited but then subsequently failed radiofrequency ablation. So you have facet-mediated arthritic pain of the low back. That's a pain that starts to one side, feels like it's in your butt, goes out into your hip, and then often burns on the outer part of your thigh. That's joint pain. Your MRI shows facet arthropathy. Look for those words in the report. Your X-ray shows arthritis of the facet joints. If you have that pain confirmed at the same level by those imaging findings, then you have facet-mediated pain. You're a good candidate for radiofrequency ablation. The test for that is called medial branch block. If you pass the medial branch block test, you get 85% relief through the treatment window. Then you go on to RFA, which 60% of people benefit from for 10 months, but eventually that stops working. Then you need direct visualized rhizotomy. Now, the question Noreen asked is, does insurance pay for direct visualized rhizotomy? The answer is, as it always is in healthcare, it depends. It depends on your insurance policy. Direct visualized rhizotomy is a new procedure. It is not on the approved guidelines for any insurance. So if you have health insurance that is HMO based or health insurance that is Medicare, they have a rigid set of guidelines. If you're on the guidelines, you're covered. If you're not, you're not. DVR is not, so it's not covered. If you have health insurance that has out-of-network benefits and your company is paying the premiums, then it's really up to your company and not the health insurer, then yes, you can get coverage for DVR. How much will it cost? If you're on insurance, it will cost your out-of-pocket cost for the insurance. If you're not on insurance, it would be a cash price. A typical cash price for a direct visualized rhizotomy, depending on the location, is somewhere between $5,000 and $15,000. So that's the answer. All right, next question. Matthew Hawkins. I have lost the ability to walk from my severe stenosis. Oh my God, I'm so sorry, Matthew, I'm so sorry. But everyone watching this should understand that everyone will ultimately lose the ability to walk if they let their stenosis go on long enough. That's why you really don't want to get to this point, but brother, you are, so let's talk about it. I'm sorry to hear that. I was told that my spine is so bad, along with my being obese and diabetic, that there's really nothing they can do for me. False. 100% false. So diabetes and obesity are risk factors for surgical morbidity. You're more likely to have a complication. In surgeons' language, in the surgeon's calculus, they need to weigh the risk of a complication against the risk of the surgery, the risk of not having the surgery. In your case, the benefit of the surgery is the ability to walk and not die, so you can tolerate a lot of risk over here. Risk factors like diabetes and obesity are nowhere near the risk of certainty of continued morbidity with spinal stenosis. That is false that they can't do anything for you. They can. Now, there are rare circumstances if you have aortic stenosis, and we know that if we put you under anesthesia, your heart's going to stop. Yeah, certain death due to anesthesia would be a contraindication to surgery. But risk factors like diabetes and obesity, no, that's a risk. Your surgeon was weak. They're lying to you. They're not lying. They're just not being they're not being truthful or they're not informed. You can find someone better who can take care of you. I'm 48 years old and completely handicapped now. Yeah, I know. It doesn't matter how old you are. It's the stenosis as it progresses will get you. I've lost feeling from my waist down and my hands. Your hands are not due to spinal stenosis in your low back. So either we're talking about spinal stenosis in your neck or there's something else going on. All this happened in the last 4 to 5 months. Yeah, usually what happens with spinal stenosis is it goes really slow until it goes really fast. So 99% of the narrowing may occur over your whole life, but then that last 1% is what makes you symptomatic, and it can go very quickly, even over a period of months. You got to be on the lookout for it. It's destroyed my marriage. Yep. My pain levels are off the chart. Yep. Pretty much just hoping for death at this point. Nope. Where there's life, there's hope. You've been given wrong information that no one can help you. It's not true. The situation when we're sick is depressing. We tend to focus and ruminate on the negative, and that can block us from taking effective action to get better. What you've told me in your question is as fact that no one can help you is not true. There are doctors who can help you. Get on the phone and call us, 602-256-2525 in Phoenix. We're going to look for doctors in your community who can help you. I will help you. There isn't no one who can help you because I will. Call us and we'll do our best to find a surgeon in your network, in your community who actually can help you get better, because there is one who can. All right, what else we got? This is from Cumbrian Macam 2 days ago. Cumbrian, I was lifting far too heavy weights and with poor form when I heard and felt a terrible crack in my lower back, which left me in severe pain, sciatica, for around 2 to 3 weeks. Yep, I've been there. I don't know that you're male, but I'm just gonna go out on a limb and say a lot of guys in the gym, man, it's intoxicating. The more you lift, the more jacked up you get. It's just like, give us a club or some heavy weights, and all the worst parts of our personalities just come out. But anyway, this is very common. So you're lifting a really heavy weight. That predisposes you to putting force. When you're in a deadlift in particular, you're bending forward. So you're putting tremendous torque on your discs, heavy weight on the lift, and you get internal disc disruption. That's a tear in the tough outer part of the disc, and that tear results in either a herniated disc, which inflames the nerve root and causes sciatica, or just a painful annular tear, or neither. In many cases, it heals on its own without incident, but that's the situation we're dealing with here. By the way, so the sciatica went away in 2 weeks. Sciatica is the sensation of pain going down the leg from the low back in the distribution of the sciatic nerve. There's a really good picture of it right here. It's the red. This is the sciatic nerve, and here are the nerve roots which give rise to it, and they're showing it in red to indicate that it's a sense of electrical pain shooting down. That's sciatica. Most of the time, sciatica goes away by itself, and no treatment is needed. We don't know the exact percentage, but it's definitely above 90%. In the case of nonspecific low back pain, which includes sciatica, it's 94%, goes away within 12 weeks, 86% goes away within 6. So it goes away, but it takes longer than we would wish and hurts like heck. Glad, Cumbrian, that yours went away in 2 weeks, 2 to 3 weeks. That's on the merciful side. 2 years later, I have no sensation in my right upper thigh and constant pain between my shoulder blades. The right upper thigh is usually the L3 nerve root. So your torn disc was probably your L3-4. It could be L2-3, but it's usually L3-4. And that would indicate you had a lateral disc extrusion and it's hurting that nerve. I would imagine you're also weak in your quad, which helps you straighten your knee. You're also probably weak in your hip. If you try to stand on one foot and do a squat like a Bulgarian, my guess is that you're weak in that movement as well, but that's a separate matter. Shoulder blades is a different issue. So we're talking about low back with sciatica, weakness between the shoulder blades. That's in your neck, your spine, and you may have something up there too, but it's a separate problem, ticks and fleas. They look the same, but they're not the same thing. My lower back cracks and pops the whole time when I move and lift things, and I'm constantly living in fear that my back will go out again and suffer from sciatica. Yeah, having a back problem is like having PTSD. The pain is so severe and it's so right into your soul that you start to develop fear. And you get that what you do can trigger it. So you start to get into this weird shame, PTSD, crazy handicapping nastiness that is the cycle of hell for people with back pain. The way to get out of it is to find out what's wrong and find out what the evidence-based treatment is. By the way, in this entire discussion, I haven't heard any MRI language, so I'm thinking that you haven't had an MRI, Cumbrian. And spoiler alert, I'm going to recommend an MRI at the end of all this, but let's keep going. Oh, one more thing. Cumbrian notices cracking and popping in the low back. Cracking and popping is facet related. Cracking and popping is the facet joint in the low back. You know how your knuckles crack? Well, joints crack. In the low back, that's the facets. That's what's cracking and popping. So if you're having cracking and popping pain, then you have to start thinking facet. And that facet pain pattern, 90+% in the back, goes out into the butt, feels like it's in your hip, and burns on the outer thigh. If you got those two things and you can't get an MRI, think X-ray. Just an X-ray is really helpful in showing that facet arthritis. And X-rays are much less expensive than MRIs. Cash price for an MRI is often about $350. X-ray cash price usually under $50. So better deal. I'm constantly in fear my back will go out again. Will my situation eventually correct itself because it's gradually having an effect on my mental health? I'm so sorry, brother. I'm so sorry. Yeah, it's PTSD. It's normal to be feeling abnormal, and I'm sorry that's going on with you. And no, it's not likely to, you're 2 years out and you're still having these symptoms. 94% of nonspecific low back pain cases heal on their own within 12 weeks. Of those remaining 6%, there's not a lot of healing after that. Some for a herniated disc, but for the most part, you're dealing with issues that do require treatment. And so I would suggest that you need to muster up the resources. The next step is to find a doctor and get the necessary imaging to go on about your business and find out what's wrong and get it fixed. I don't know your age, but you're working out. I'm thinking, maybe I'm stereotyping here, but I'm thinking you're relatively young. So the cost may not be insignificant and the logistics may not be insignificant, but you really don't have a lot of other options. I always tell young people, look, you're living through the dog years of your life. Every year in your early 20s is like 5 years when you're my age. Your life changes and your development is so fluid. Where you live, who you live with, how you're going to go about things. It's very, very fluid and very active for you. That means it's more important to get things taken care of. You can't just sit on this stuff because pretty soon you should have been doing that new job. You should have got that promotion. You should have tried that new thing. You should have explored your passion. You didn't. And now you're getting older and you're going to miss your window. When you're young, it feels like you're going to be young forever. And boy, that's just not true. So get it fixed. Jump on it. I know it's hard. You're never poorer than when you're younger. I know it's hard. I know it's tough, but figure out how to get the resources to get this thing going. By the way, one really good resource is me. I'm free. Let me know. If you want to take a closer look at your case, then click through to our website, phoenixspineandjoint.com. Hit me up on that get more content like this box. Submit your question. My staff will work out getting you on the show. I'd love to spend a good amount of time unpacking your bags, figuring out what's wrong, and trying to get you on the right track. All right, what else we got here? Spooky Teeny. Spooky in your picture. Okay, Spooky. I'm 19.3, herniated discs in the lumbar spine and 2 in my neck. Sciatica is killing me and severe back pain. I just want to know why I'm so young. You know, I think you're saying you're 19 years old. My youngest child is 23, so you're about the age of my kids. You should never blame your parents except for now. This is your parents. So we inherit the materials that our discs are made out of, the proteins and tissues that compose us come from our genes, right? They're encoded for by our DNA. And chances are really high, Spooky Teeny, that one of your parents had back problems. So you don't blame your parents, blame the one that had the back problems, because they're probably the one that gave you this. Now, that doesn't mean by any means that you're destined to have back problems. That doesn't mean that you're condemned and there's nothing that you can do about it. That means that, oh, I'm sorry, I can't read that. Oh, we got a question. Okay, cool. We'll go over to the question on the chat in just a second. It doesn't mean that there's nothing you can do. It means that you have more resources because you have family support. Your family knows there's something wrong and what it's like to have back issues, and lean into your family as part of your support system. Disease requires a team. Illness is a team sport. So you want to make sure you're leaning into your team for that. All right, we got a question on the chat. Let's see if I can uncover that. Sorry, it's going to be over here for me, and I can't do it. Let's see if I can get this. Oh man, my live chat's not coming up. Well, I don't know. I guess I can't get there from here on this monitor situation. What? Spooky Teeny. I'm looking at Spooky Teeny. Hold on. We're trying to figure this out. All right, the question we have through the live chat is from Zinli Radebi. I'm too fat. My weight is 115 kilograms to have hip replacement. Oh, am I too fat to have hip replacement? My doctor says lose weight and I can't because of the pain. No one is too fat or too young to have total hip replacement surgery. That is a legacy misnomer. It's not true. Your doctor's wrong. You have a little extra risk having surgery of a blood clot or other things, but the latest registry data from Australia would indicate that you actually don't have a higher risk of needing to have a revision. So no, nobody is too fat to have total hip replacement surgery, including you. It's not good to be fat. I know, I've been there most of my life. It's not good to be fat, so you really should look at losing weight. I would recommend that you target a BMI of 40. A BMI of 40. BMI is your height divided by your weight. And the way you can calculate your BMI is by going online and Google BMI calculator. Or go to my website. I have a BMI calculator on phoenixspineandjoint.com. So calculate your current BMI. If it's above 40, then think about, hey, what could I do to get under 40? Why 40? Because that's where you're safe in your to undergo anesthesia in an outpatient surgery center. Your anesthetic risk is going to be a lot less if your BMI is under 40. So hit up your BMI calculator, find out what, by the way, once you have your BMI, if you're above 40, start typing in lower weights until you keep your height in the one box and start typing in lower weight to see what your weight would have to be to get you to a BMI of 40. And once you see that, that's your goal. I have had patients who, honestly, by the way, diets don't work, right? If you look at a 5-year recurrence rate or probability of regaining the weight, there's never been a diet that is successful. Most people who are unusual, spectacular, and overachievers, the top 1% of dieters who lose weight and keep it off, they did keto with intermittent fasting. So if you think you can lose weight by going on a diet, but go on keto with intermittent fasting. But the reality is it's very unlikely. On the one hand, the thing that almost always works is a gastric sleeve. So obesity surgery is highly effective. My recommendation to you, if you want to get some weight off prior to surgery for your hip, would be go ahead and see an obesity surgeon, see about a gastric sleeve. That sleeve will help you get your weight down. If your hip still hurts, boom, you'll be safer as long as your BMI is 40 or less to undergo surgery. But am I too fat to have surgery? No, ma'am, sir, whoever you are, whatever you are, no, you are not. No one is too fat or too young to have total hip replacement surgery. It's bogus. All right, next question. So that was a good one. My screen is going insane. All right, Leah Tomo. My wife has 2 microdiscectomy surgeries with no relief. Injections have not worked, and recently she's been bedridden with pain in her leg. We just don't know what to do next. Ikes, first of all, I'm sorry this is happening to your wife. Pain, when your spouse is in pain, it's almost worse than when you're in pain. Watching someone you love suffer is just a really, really difficult thing to do, so I'm sorry for that. Microdiscectomy fails because of one of 2 reasons. Either they didn't get all the herniated disc out, or the disc, they got it all out, but now more is coming. All right, so A or B happened. Now she's had a second surgery. Same 2, either they didn't get it all out or more is coming. Most likely more is coming. So from a what do we do now standpoint, we have basically 2 options. Wait it out, which is what you're doing, because there's a good chance over a long period of time that it's going to heal on its own, or have a fusion surgery. Fusion surgery is where they go in and scrape out the entire disc, put a spacer in, and then pedicle screws to lock it in position. That kind of operation, if it's the L4-5 or the L3-4 level, is done from the back. If it's the L5-S1 level, and she's not too heavy, it's typically done from the front. But either way, what do we do next? If it's have surgery, it's get a fusion surgery. Choosing a doctor for fusion surgery is not always the same as choosing a doctor for microdiscectomy. Sometimes you want to get a different doctor. So definitely call us or connect through the website so that we can rate your doctor. You know, you guys, if you send me the name of your doctor, my staff will look them up, and go through the rating process. We'll tell you, with spine surgeons, we've got a 5-star rating process. We'll tell you who's good and who's not. Just because you love your doctor, just because your doctor's nice, just because that your cousin had a good result, doesn't mean they're a top world-class doctor. Doesn't mean they're a top world-class doctor. To be a top world-class doctor and best practice doctor, we'll rate them. So click through, let us know, and we'll find out what to do. Sorry about your wife. I know how painful that is. How long does sciatic nerve take to get better? This is from Nadine Blake. Hi, Nadine. Thank you for the question. Sciatica, again, is pain pain shooting down the leg from the back and the distribution of the sciatic nerve. It's usually caused by a herniated disc. Most herniated discs resolve on their own without any intervention in 12 weeks. Most will be gone within 6 weeks. So 6 to 12 weeks is the typical amount. As a result of that time frame, if you have MRI confirmation of a herniated disc, then you're a good candidate for epidural injection. Epidural injection lasts about 100 hours. Off and on, you get a week or 2 of relief. So if you get that 6 weeks, if you get 3 epidural injections, you get relief for around 6 weeks. That covers it for most people. So if you have sciatica, you need and it's longer than 3 weeks, you need an MRI. And if you have a herniated disc, you're a candidate for epidural. I hope it gets better within 12. I hope you feel better soon. Ruthie Diaz, 4 days ago. Hi, Ruthie. Thanks for sending your question in. Would it hurt me to use a teeter inversion table until I actually have to get surgery? No, it will not hurt you. Teeter inversion tables are awesome. They're a form of traction. traction has been studied over and over and found not to be effective, which is misleading. So traction doesn't change whether or not you're going to end up needing surgery, but traction is a great source of relief. Traction is like brushing your teeth. The effect ends as soon as you stop doing it. So if you do traction every day for 100 days, you're going to get relief during that 100 days. But if you don't do it on that 101st day, the effect wears off. It's something you do like brushing your teeth for hygiene. It has to be an ongoing thing. But I've seen a lot of people get tremendous relief with traction as long as they have joint-mediated pain, facet arthropathy. So if you have facet arthropathy, if it's confirmed by X-ray and you get relief from doing traction, keep doing it and never stop. Ramachandran Balakrishnan. Ramachandran Balakrishnan. I have moderately severe central canal stenosis, L4, L5, and L5S1 disc bulge. I've been advised to take chiropractic and physiotherapy with a gabapentin 1 in the night. I'm walking all right with very mild pain and doing all my routine work. Feel I have a lazy bowel. What is your advice? Ramachandran, thank you for your question. There's a few things I want to unpack here because I think a lot of people have these same issues and they're really going to help. The first is moderately severe central stenosis at L4-5, but I get some pain when I walk. I'm not having bowel or bladder dysfunction, and I don't have any functional numbness or weakness. So spinal stenosis is a progressive condition. Your stenosis will only get worse from here. It will never get better. You can minimize your symptoms by staying active. Stenosis is like arthritis, where motion is lotion. Stenosis and arthritis, motion is lotion. However, it's never going to get better without surgery, and it's only going to get worse. So, Ramachandran, you're going to have surgery at some time in your life, I hope, right? The only way you're getting out of surgery, the only way you're getting off this planet without a scar on your back is by dying of something else first, which I do not wish for you, my friend. So let's assume that you're going to have surgery. Then the question becomes, when? When's the right time? If you wait too long, you'll have permanent nerve damage. If you go too early, you're getting surgery where the benefit doesn't justify the risk. So the answer is the right time is in between those. You definitely don't want to wait too long, and you definitely don't want to go too early. That time can only be met by you. When you start having symptoms in your legs when you walk that are relieved by bending, and that is inhibiting you from your daily activities, that's when you want to really, you're getting on the too late side, my friend. So you really want to think about going at the very beginning or earlier than that. I would also recommend MRI surveillance. Surveillance in the movies, that's where the cops sit outside and they watch everything you're doing. Same thing here. It's where we're going to watch what's going on in the background, but we're going to use MRI instead of our creeper binoculars, right? We're going to get an MRI. Let's say it's once a year. So in the US, the big holiday coming up is Halloween. It's on Monday. If you're having MRI surveillance and you agree to get an MRI every year, right, the week before Halloween, go grab an MRI. If the MRI shows progression and it's starting to get severe or your symptoms change, boom, trigger the surgery. Second thing, you were prescribed chiropractic and physiotherapy for your stenosis. Chiropractic and physiotherapy have no effect on spinal stenosis. They can help give you better station, make you more functional, but they don't make a small hole bigger. So they are not actually treatments for the condition of spinal stenosis. Chiropractic and physiotherapy, I love chiropractors, they're great doctors. I love physical therapists, they're amazing. They're amazing students of the body, and just like I hope to be myself, but it doesn't work for spinal stenosis. It's just a fact. Well, then what about, oh, by the way, another thing that is often misprescribed for spinal stenosis is epidural injection. Even Medicare allows epidural injection on their approved guidelines list for the diagnosis of spinal stenosis. That's incorrect. We had a randomized controlled trial published in the New England Journal that looked at epidural for spinal stenosis and found no benefit. We've also had several randomized controlled trials of epidural injection that were done with sham injections, found no benefit. There's no benefit to epidural injection for spinal stenosis. And why would there be? The hole's too small, people. You have an epidural injection. The hole's still too small. You're more likely to have an epidural complication and the hole is still too small. It just doesn't make sense. It's been proven not to be true. Don't do it, it's dumb. Last, I've been prescribed gabapentin 300 milligrams each night for the leg pain due to spinal stenosis. This is wrong on two levels. First, gabapentin is a suppressive drug. It's actually an anti-epileptic. It was found accidentally to reduce nerve pain due to sciatica, but it's a suppressant. It has to be present at all times. It's a drug that would have to be taken 3 times a day. Taking gabapentin once a day is misuse of the drug. It's not going to suppress anything. You're buying all the side effects of the drug, headache, confusion, fuzzy thinking, etc., without even getting a chance at any of the benefits. So number one, you're taking it wrong. Number two, it doesn't work for this anyway. The hole's too small. If you reduce the threshold for neurotransmission using an anti-epileptic drug like gabapentin, the hole is still too small. It's dumb. It doesn't make sense. It's not going to work. It's a dirty, dirty, dirty drug. It affects your brain, and you don't want to take it. I strongly recommend, if you are being prescribed gabapentin for pain related to spinal stenosis and you're healthy enough to have surgery, then you need a new doctor because yours doesn't know what they're doing. They're prescribing the wrong medications that have enormous side effects for the wrong condition. Don't do it. That is my advice. Oh my God, I'm sure I sound very opinionated. Dan Scott, I have a transplanted kidney and I can't take too much acetaminophen. Correct. We'll unpack that in a minute. MRI reveals a ton of issues causing pain. What other anti-inflammatory drugs are outside of steroid injection? Tylenol and gabapentin helps. Pain is what it's doing for inflammation. Thanks. All right, so acetaminophen at more than 3 grams a day has a horrible risk for the kidney. Dan has a transplanted kidney. The last thing you want to do, someone had to be a donor for that. The last thing you want to do is act irresponsibly and damage your new kidney with the Tylenol. So no, Tylenol is not a good option. Non-steroidal anti-inflammatory drugs are no spring picnic either. They're very hard on kidneys and can cause acute renal failure, especially when they are used chronically. Dan specifically asks, so by the way, the only thing that's left is aspirin, which is a reasonable drug. But to be honest, we're always trying to avoid steroids, but this is one situation where I would actually I would be more inclined to go with steroids. Steroids are actually less risky for people with renal failure, especially when they're injected to the problem in high dose. Last, look, whenever you have surgery, you have to look at the risks, benefits, and alternatives for surgery or any other treatment. In Dan's case, the risk of medical management is actually higher than normal. That means the relative risk of surgical management is lower. So Dan, not only should you be thinking about maybe aspirin, but you should also be thinking about maybe surgery. Send me your stuff. Let's take a look at it together. Let's see if surgery is an option for you. People with kidney failure heal just like everybody else. Yes, you have some immune compromise, but don't overlook the one thing that can help you, which may be surgery. Sergio, and what's the price of epidural injection? Because I'm getting one every 2 weeks just for curiosity. Man, I unpacked this like a border control agent with a high level of suspicion. My wife and I were flying back from London once, and this border guy clearly didn't like my wife, and oh boy, he went through every single item in her suitcase. I did that for Sergio's question on Best Practice Live earlier this week. I also wrote a blog that's being published that went through in detail. Long story short, whenever anybody asks about cost with regard to a medical procedure, I want to look at 2 things. What's the cost of goods? In other words, what's it cost somebody to actually provide the service? Second, what's the out-of-pocket cost to you? Both are complicated questions, but they're worth knowing the answer to. When you buy a car, I want to know the cost to the dealer so I know how much markup they're getting. And look, no money, no mission, right? They have to to be a sustainable provider, they have to make some profit too. I'm good with that. But I want to know that I'm paying a fair price. And that depends on a lot of things like the cost of goods, the rent, the equipment that's necessary, the use of disposables. And then on my side, for out-of-pocket costs, that depends on what kind of insurance I have, whether I even have insurance, and what my position with regard to my deductible, out-of-pocket max, and co-insurance is at the time of the injection. Complex? Oh yeah. Messy? Definitely. That's why I provide a calculator on the website, phoenixspineandjoint.com, which can actually do this math for you, because I know how much you love math. And my zero, by the way, not one person has watched my video on the odds ratio. Not one. I mean, I can't tell you how it breaks my heart and how offended I am. I wish you guys would watch it. Ghost Tech, I'm 40 years old. 2012, I was mild left back pain in the lumbar. Then I took medication and 1 month of exercise, then I quit and back to a normal life. Mild pain is there all the time. And 40-year-old with mild back pain, okay, but it doesn't bother me. Now for a few days when I bend forward and I take my 10-year-old daughter, I suddenly felt pain on the left side. As a result, I can't bend forward. I don't feel any pain in my legs. How can I get back to a normal life again? I consulted a doctor. He said after the pain is gone, I can start exercises for my back pain. Now I'm taking over-the-counter pain medicine, painkiller. I don't want to take a painkiller, so I want it to stop. Can you suggest something how I can bend forward after some time? Pain in the back that doesn't go down the legs, that's a stabbing pain, is classic for an annular tear. An annular tear is a rip in the outer part of a disc. It's also often called internal disc disruption. The treatment for annular tear is for the annular tear to heal on its own. If that doesn't happen, you can look at a stem cell injection into the disc. If that doesn't work, then the atomic bomb solution is fusion, where the disc is removed and the bone is allowed to heal to itself. There is no medication which works well for this kind of pain. So you're right, you don't like to take meds and they don't work very well. Don't take them. Learn to live with it. Sitting is going to hurt. Standing and bending is going to hurt. Try not to sit, stand, or bend. Try to stay as straight as you can. You're on the right track when you say, when I get better, I'm going to start doing core strengthening exercises. You got to really watch core that bends and crunches on the spine. So when you do start back to the gym, Ghost Tech, you want to go do isometric core exercises. Those are planks, just holding yourself and holding your body. Start out, try to get up to a minute, then try to get to 2 minutes, then try to get to 5. Usually only prisoners get to 7, people with unlimited time on their hands. But do your best and build up your core without doing things like crunches that put weight on the discs. Good luck to you. It's a bad problem. I'm sorry to say it's a bad problem to have. Solomon Nissen, 9 days ago, what's the fastest way to recover after surgery? I've got meniscus injury to my ACL. It's completely torn apart, and my PCL and LCL are also torn. Let's just do, this person has an ACL injury along with other ligaments in the knee. The knee is certainly unstable. Reconstruction of the ACL is strongly recommended to get back to a normal life. ACL reconstruction surgery takes about an hour and a half maybe. It's done on an arthroscopic basis. A graft is placed where it's bone with tissue in the middle. The bone heals in, and so now you have a new ACL. But the bone healing in takes weeks to months, and then you have to strengthen. So the recovery from an ACL the operation is ingenious, the recovery is prehistoric. It takes months to make a full recovery. To get back to same sport athletics is usually 5 to 6 months. So it's a very slow recovery, but it's your cross to bear. You got to do it. There's no other way to reconstruct your ACL. Why can't I just have my ACL repaired and it'll get better faster? Because they don't heal on their own. We repaired ACLs for years. The results were crap compared to what the sports medicine orthopedic surgeon does today, which is the reconstruction. Someday we may have stem cell options that allow us to go back to repair. Today, that sounds great. Today's not that day. Baha Al-Rawi. I've been on the fence for a few months now. I was advised to take RFA for my facet joint arthrosis. That's been painful for 8 years. Should I do it, doctor? There's no DVR where I live. Yes. If you had a medial branch block that relieved more than 80% of your pain through the treatment window, the medial branch block is the best test we have to simulate the results of a radiofrequency ablation. So yes, if you had medial branch block and you were successfully relieved for 85% of your pain was gone through the treatment window, then there's a 60% chance that 80% of your pain will be relieved for 10 months. Let me say that again. So you should do RFA if the benefit is worth the risk. There's almost no risk. There's literally no alternative after physical therapy. So the benefit is 60% of you will get 80% relief for an average of 10 months. If that sounds good to you, do it. That's the end of story. If that sounds good to you, do it, because there really are no other options. If you don't want to do it, you should be on an anti-inflammatory diet. You should be taking anti-inflammatories on a limited basis as needed. You should be active every day because motion is lotion. But if you're doing those things and you've maxed out your lifestyle and you got 85% with a medial branch block, then you have to decide if something that's very, very, very low risk is worth a 60% chance of getting 80% relief for an average of 10 months. And if the answer is yes, do it. If the answer is no, don't do it. But I think you should do it. It makes more sense to me. All right, Craig Dennis asked, I have a herniated disc which has not healed after about 6 years. I've had facet joint injections, but that didn't help. I played golf last week, played a shot, and I thought I'd been shot in my back, right where the dimple is in my butt. It was agony. I'm not sure what to do next. Craig Dennis, you're describing an annular tear. So it's a shot in the back or a knife in the back that occurred when you were applying force through the golf swing to your back. You likely have internal disc disruption. Assuming you have no leg pain, you should sit tight for 3 weeks. If the pain's not getting better, despite rest, moist heat, and anti-inflammatory drugs, then you should see your doctor. Your doctor will recommend an x-ray. If the x-ray doesn't show anything, you should wait 3 more weeks. At the end of 6 weeks, if you're not getting better, you should get an MRI. If the MRI shows internal disc disruption and the pain is just unbearable, then your choices are stem cell or steroid injection into the disc versus fusion, which is usually just way too much. Or now we have something called the Intracept procedure where they denervate the disc. So those are your options. All right. Beach Junkies. Oh, I like your handle, Beach Junkies. I myself went to college in Malibu, so I was a 4-year beach junkie too. My back hurts since late last June. This year I couldn't even walk or stand up because I was bedridden because of it, and I can't get to the doctor to get looked at. I've always had back problems since I was younger, so I thought it was acting up again, but I've never had it this bad so as to make me bedridden. I bought a walker, and I guess it's trying to heal up on its own. I can finally get to the bathroom, and now I can sit down and get into a shower. I have to use a back brace just to help support my back. I'm trying to get it up, and I'm more hoping that I can get into the car and go to the doctor appointment. What do you think? I still take medicine for the pain, and it's way better. It's going on 4 months now. So we're 4 months into this. We don't have any imaging because we haven't been able to get to the doctor. We don't have any discussion of pain in the legs, numbness, weakness, so there's no sciatica. So this is almost certainly either discogenic back pain or it's facet pain. From the sound of this, 4 months in, I think it's more likely facet pain. So the treatment of facet pain is get an x-ray If that confirms it, get an MRI. If that confirms it, if you're tender to palpation of the facets, then you're going to need to see a pain management doctor. The pain management doctor is going to do a medial branch block, then radiofrequency ablation, and that will get you relief. So I know it's a lot, and I know it's a whole process, but the back pain is a complex problem that does require a team. It's expensive, but there's really no other way. So that's what you should do. L. Dr. KC. I don't know, are you a doctor in Kansas City? I hope so. Why do we keep putting Band-Aids on a damaged disc? My disc is bulging and compressing the spine. Why can't we fix this instead of waiting for permanent damage? Yes. Well, it's not like we haven't tried. A lot of research has gone into why don't we have any therapeutics that help discs get better, right? It's a great question. The answer is not like we haven't tried, but we have not yet succeeded. We're working on it, and someday we will have things we can inject. They will likely be stem cell-derived proteins, in my opinion. They will likely be nanoparticles that help knit together a basement membrane associated with growth factors that encourage the right healing to get these structures like the disc that have very little blood supply to heal better. But today is not that day, but someday we will. Prem Kumar. Hello, doctor. Hello, Prem Kumar. Nice to see you. The issue I mentioned below is the same as a herniated disc, and here's the issue. I think he's pasted a MRI report. L4-5 central disc protrusion, mild posterior disc bulge, spondylosis causing spinal canal stenosis, thecal sac compression, cauda equina compression, bilateral traversing L5 nerve root compression, bilateral neuroforaminal stenosis. This is the most jargony MRI report I have ever seen, but yes, it is the same as a herniated disc. L4-5 central disc protrusion. Protrusion means the soft part of the disc has protruded through the annulus, and that word protrusion is the same as the word herniation. By the way, I love what Prem Kumar is doing. They're looking at their MRI report and hopefully matching it up to their pain pattern, because that's what determines what the next step is. So they're doing exactly the right thing. Now you go get your MRI report. If you see the word protrusion, then most of the time you're dealing with a herniated disc. If your symptoms are sciatica, then you fall into the herniated disc decision matrix. If your problem is protrusion, that's the same thing as extrusion. That's the same thing as herniation. Your problem is a herniated disc. If your symptom is sciatica, then you're a good candidate for either an epidural injection for temporary relief, or microdiscectomy if it's gone on for more than 12 weeks and you don't have functional numbness or weakness. So yeah, there's a lot to unpack in that, and it's complicated, but you can do it, right? You can do it. By the way, if at any point you're just like, no, I can't do it. You're like, I just don't, I need help. That's what I'm here for. Call me. Click through, go to phoenixspineandjoint.com, go to the best practice page. We're getting up a better call to action for that, but what we have right now says, get more information like this. That means I want to talk to that guy because I don't know what to do. Or that means I want to get my doctor reviewed because I'm a little embarrassed to call up and ask them these questions myself. That's not my relationship with my doctor. I'm going to need some help with that. Well, that is my relationship with your doctor. I can do that for you. Or I want to know more about the latest information that's out there. I want to see more studies like this, etc. That's what that means. So feel free to jump on board and do it. Okay, by the way, on the rest of this MRI report, the central protrusion is a herniated disc. If you have sciatica, then you fall into the herniated disc decision-making matrix. Mild posterior disc bulge. Bulge means the disc is intact in the annulus and it's pushing out, but it has not herniated, protruded, or extruded. Thecal sac compression, that means you have narrowing, that's spinal stenosis. Cauda equina compression, bilateral nerve root compression. The radiologists are describers. They're not telling you, they're telling you what they see, not what you should do. So oftentimes they're describing, oftentimes it's raining and it's cloudy and it's gray, right? That doesn't mean you have three different things. It means the clouds are in the sky and they're dropping rain. Sometimes we get into that, and that's kind of what's going on here. It takes a surgeon to look at these complex images and unwind it with you and determine the right thing to do next. Hi, doctor. Hi, Koala and Lion. Nice to meet you. Thanks for your question. Thanks for your very informative video. You are more than welcome. It's a pleasure. It's really fun to reach out to you guys. You know, I'm someone who spent 20 years seeing patients one-on-one. I've now got 100,000 people a month looking at my content. I love that. I love that. I love the idea that you're all out there and I didn't have to say it 100,000 times. so thank you, Koala, thank you for watching. My question is, does having a second fusion surgery probability applies for L5S1 as well? Yes, 17% of people who have a fusion surgery have a surgery at the adjacent level within 5 years. And for the L5S1, although that's the bottom, the adjacent level is the sacroiliac joint. So even though it's L5S1, you're not, Koala saying, hey, there's only one adjacent level and that's on top, so my risk should be half, right? Wrong. There's two adjacent levels. It's just the second one is the sacroiliac joint. What do you think the best surgery or procedure for foraminal stenosis caused by L5S1 isthmic spondylolisthesis is when there is unilateral leg heaviness and weakness? Thanks again. This is a great question. Spondylolisthesis is the shift of one bone on another. Isthmic spondylolisthesis happens because the facet joint, part of the bone called the isthmus, is incomplete, and so that's allowed the bones to slip. When that happens, the spinal nerve root gets pinched in the nerve canal or in the foramen, the hole that it goes out of. For years, doctors, we tried to do a decompression surgery on this. That's very appealing because it's minimally invasive. It often doesn't work. I believe the best solution is spinal fusion with pedicle screw fixation and an interbody graft to pull the spondylolisthesis as much as you can back to the neutral position, which opens the foramen and allows the surgeon to decompress the nerve root. So my answer is spinal fusion for the condition that you just mentioned. Oh my God, it's 10:58 here in Arizona, but I think I've only got 3 more. Let's try to go through them real quick. Julie Berry, hi, awesome info, thank you. I had ACDF at C4 through 7. I'm still experiencing a burning pain in my neck, my left arm. What about going from ACDF to ADR? ADR, I think she means total disc replacement in the cervical spine. No, you really can't. If you've had ACDF at a level, I would not recommend considering a disc replacement at that level. If you want to have disc replacement adjacent to a prior ACDF fusion, that's an option. Having said that, if you're having arm pain after ACDF, your problem is residual nerve root compression in the back, and what you need is a cervical foraminotomy. That's an old school operation. Look for an older neurosurgeon. We were the old guys. We're good for something. We're good for that. Next question. Nora Zelaya, after an accident and an MRI with diagnosis of spinal stenosis, doctor assumed I was having lots of pain. I'm lucky I can walk, discomfort. I'm not on any painkillers. I'm taking Tylenol. At 65, I went for my first Medicare visit, was diagnosed with prediabetes and osteoporosis. I had hip and knee pain too, thought it was osteoarthritis. X-ray denied that. I went to research mode, went on a moderate ketogenic diet, sugar elimination, vitamin B12, helped me a lot with my musculoskeletal pain. Good for you. That's awesome. Resolved my pre-diabetic problems. I continue my diet and exercise. So far, so good and more energy. This is my experience. Heck yeah. Good for you, Nora. Strong work. You're absolutely, what you're experiencing, I've seen happen in many other patients. You got to keep it up, right? Don't gain weight. Don't go back to sugar. Avoid that inflammation. And don't fly blind. Don't be a blind pilot. Figure out what your body's inflammation is doing by measuring your CRP. CRP, C-reactive protein, is the doctor's value of internal inflammation. You wouldn't fly on a plane with a blind pilot. Don't do an anti-inflammatory diet without knowing what you're doing. So I would strongly recommend you watch my video, The Toast, 5 Healthy Hacks to an Anti-Inflammatory Diet. The last T is measure and track changes in your CRP. Strongly recommend it. All right, last question. Thank you for this review of the most relevant study to me personally. I'm 60, I have a buckle handle tear on my meniscus. MRI says too much damage, no blood flow to repair. I'm in decent shape, 6 feet, 200 pounds, 220, trying to go to 200. I wanted to get scoped and get it done after rehab, but I can't find a surgeon who wants to do that. So I'm looking at trying to keep off total knee replacement. Hey, JC, thank you for the question. Normally, if you're over 50 and you have a bucket handle tear, you're not necessarily a good candidate for meniscal repair. But what you can accomplish changes with your capabilities as a surgeon. Some surgeons, these guys are just so damn good that they can do stuff that other people can't. I did check with one of our surgeons, but guy's 60 in good shape, has a bucket handle tear. Is he possibly a candidate for meniscal repair? My surgeon's answer was yes. Click through and contact us. We'll hook you up for a visit with that guy and see if that would make sense for the two of you. Thank you so much for your patience. We've covered a crap ton of ground today. I hope I didn't sound, it feels like a rant. It feels like I've been ranting at you, but I really wanted to get through all the questions. We'll do the same thing next week. I really appreciate your questions. It's why we're here. Please keep them coming. Have a great day. I'm Dan Lieberman for Best Practice Live. If you have a question you would like answered on Best Practice Live, there are 3 ways to ask. Leave a comment on any of our social channels, click the link to our website and complete the submission form, or call or text us at 608-602-4022. The more information you can give us, the better we can answer your question. So please contact us and we can walk you through uploading your imaging to a secure server. Please like and subscribe to our channel to stay up to date with information about your spine and joint health. Lastly, be sure to check out new episodes every weekday at 10 a.m. Pacific, 1 p.m. Eastern, where we answer all your questions.